This is going to be pretty data intensive or information intensive, kind of like the last talk I gave and I think the first talk I gave. And I think this really relates to the fact that, as we talked about before, each person who has Dyskeratosis Congenita, one of the telomere disorders, is different from everyone else, right? Even within families. So there's a lot of things that we have to consider. And so I might talk about something and you might be thinking, oh, that has nothing to do with me or my child, but it may have something to do with one of you in the room. And so I'm hoping that, you know, we cover things that are relevant to everyone at least one point or another during this time. Okay? So we're on part 2. Last time I told you there were several areas that we needed to screen. And we were in the middle of talking about bone marrow problems. We didn't get to myelodysplastic syndrome, and I'm going to touch on that briefly now. And we're going to talk about the immune system and some of these other systems, which I think are important for us to know about. Actually, I'm not going to talk about bones. I'm sorry. And we have a special talk on pulmonary fibrosis this afternoon, right? Really important. So I'm not going to touch on that, but I'm going to talk about something else that's going on in the lungs that we recently learned about. Okay. So myelodysplastic syndrome, you've heard about this. For many people, bone marrow problems in the telomere disorders is the bone marrow failure, which often is referred to as aplastic anemia, not enough cells, and we talked about that yesterday. Now, aplastic anemia, again, the bone marrow is quite empty. In myelodysplasia, the bone marrow can be fairly empty, or actually it could be filled with cells, but the difference between aplastic anemia and myelodysplasia is these cells are not normal in their appearance, generally, and they're not going to go on to develop into normal cells. So when you have an aplastic marrow, you may have cells there, not enough, but you got them, but they're able to produce normal cells. Here, you've got cells that are there, but they're not even doing their job very well. So the cells that they do produce, they may go into the bloodstream, but they don't survive in the bloodstream very long. They have a shortened lifespan. They tend to accumulate in the bone marrow. So sometimes, you know, the bone marrow cellularity may go from 20% to 40%. And at first people are like, oh, yay! But it's because the cells that are now starting to populate the bone marrow are ones that just aren't normal cells. And of course, our big concern as well is that this could progress to leukemia. But, you know, MDS is a problem that needs to be dealt with. And sometimes people talk about it as pre-leukemia. It can have cytogenic abnormalities. And for all intents and purposes, we need to treat as if they're very similar in many respects. So in DC, we know that there is an increased risk of MDS. And so again, the group at the NCI, Dr. Alter and Savage and others, have looked at this question in their group of patients. They've looked at retrospective data, so things that had happened in their population before they entered the registry, and then what happened in their population over time. And they looked at how many cases of MDS were observed in these individuals, and they were able to calculate what would be the incidence in that population over time. And you can see here it's almost 40% estimated by the age of 60, so you got this group here between 40 and 60, okay? Now if you compare this to the general population, if you see how many cases they saw in that group, and compared it to data that we know for the general population, the number of cases that were observed versus the number of expected, the ratio here is over 2,000-fold. So that means like over 2,000-fold risk of developing MDS. So it's a significant problem. And then also it's important to note here is that, you know, cases of MDS, they can be observed in younger children with DC. It can happen, but more often it's happening as people age, okay? Just like MDS in the population of individuals who do not have DC or one of these known genetic disorders, I mean, MDS is generally a disease of the elderly, right? And so it's just happening much earlier and at a much higher rate, but it does increase the risk over time. So, you know, when and how do we treat MDS? So first of all, we look for these changes in the way that the cells look under the microscope, okay? They don't look normal anymore. We look for changes that are progressive. So you might have some changes, but they may be stable for a really long time. This is why getting that initial bone marrow is important, because you got a baseline. And maybe just as Dr. Tolar mentioned, I mean, maybe that first bone marrow is severely abnormal with respect to the ways the cells look, or chromosomal changes may be present at the beginning. But more often than not, that's not what you see, but it's really good to know what it looks like. And then it's important to monitor over time. So that way you have a sense of the progression over time. So an example would be if you get a bone marrow 1 year and you don't get your next bone marrow for 10 years later and it looks abnormal, well, those changes may have been there for 5 years, you don't know, right? So that's where surveillance and periodically checking what the bone marrow looks like can be helpful for us as we try to understand the significance of the changes we see. So there are these things referred to as blasts. These are the cells that look like leukemic cells. I mean, these are the leukemic cells that we would describe in a patient who has leukemia. So if that number starts to increase, and we can run tests and tell us what percentage of blasts are present in the bone marrow, and if that number is starting to increase from very, very low numbers or undetectable numbers to numbers that are quite, they're increasing, that would be worrisome. And then there are certain chromosomal abnormalities, as shown here. Again, that would be concerning to us because we have learned over the years that these kinds of chromosomal changes are ones that lend to progression of this process to a leukemia. And really the only treatment is transplantation. And as Dr. Toller mentioned, we have to transplant patients who have a telomere disorder in a very special way to avoid the additional toxicity that they may experience with usual treatments. Now, as I mentioned, MDS is a problem that is seen in the general population, usually older people, and so there's a lot of interest in developing medications to treat MDS. And again, it's this general population that these studies have been done in, and there are certain agents that are acting in certain aspects of chromosome biology. Some of them are listed here, and these are they're used a lot these days. But there are no studies to tell us if these work in patients with DC, okay? So I wish there was, but there isn't. And so we don't really know if they would be effective or not.
Do you know if they're harmful?
Well, to be honest with you, I can't tell you what the side effect profile are of these drugs, but as for any medication that one of us would take, a patient with a DC or one of the telomere disorders, we want to know what is the toxicity profile. Is there a likelihood that there could be liver problems, right? Is there a likelihood there could be bone marrow problems? Is there a likelihood that it could affect the lungs? So those are really important questions for any medication. So, what can you do? And again, it's all about surveillance. So at the beginning, you don't have MDS, but you need to get some, CBCs regularly, as we talked about, to monitor for bone marrow failure. And again, maybe you're not going to be going back to the doctor for 6 months. Your CBC has been completely normal, or your child's CBC has been completely normal. But if you start to notice some changes that could relate to changes in blood counts, you want to bring them in sooner. And again, there's never any harm in bringing a child in. There's been no change, then you just say yay. And never feel bad about getting an extra test early because you've been concerned. If the CBC is completely normal, then checking every 4 to 6 months is reasonable, but when it starts to become abnormal, then those surveillance CBCs need to be done more often. And we just talked about bone marrow and how it's really important to look at the bone marrow. If you don't look for the dysplasia in the bone marrow, you're not going to know it's there or not. Now, oh dear, and then I think I left a slide out here. So if there is evidence of dysplasia, then again, it's a matter of seeing if it's rapidly progressive or not, starting to think about transplant choices. So all of our patients, when we make a diagnosis of a telomere disorder, we do the HLA typing up front, so we kind of know. If that hasn't been done yet and there starts to be some changes in the bone marrow, that's something you want to do right away, so you can start thinking about what are the options moving forward. But again, transplant's the only curative therapy with respect to MDS. And so preparations for that are very, very important. Now, immunologic abnormalities can be seen in DC as well. And some people won't have any, and some will. So, I showed you the slide yesterday, and we kind of focused on the left side of the slide where the red cells and platelets and the myeloid cells were being produced. But on the right side here, this is the lymphocytes. And there are different kinds of lymphocytes. Dr. Toller talked about NK cells, for example. It's a type of lymphocyte. But they do many very important things. And what we know is in some individuals with a telomere disorder, and it seems to be most prevalent in those children who have HHS, okay? Some of them, but not all of them, can be born with very severe immunologic defects. And then other people may not have them initially, but as they age into adolescence, there can be some signs of immunologic deficiencies. Now, what is the most common thing observed? And that is the B cells, the lymphocytes. We've got T cells, B cells, NK cells. And B cells are the cells that produce antibodies, okay? And so what we see most often is that these cells are reduced in number, and going along with that, there's a reduction in the level of the circulating antibodies. And so some of you may have had your doctors may have checked an IgG level. IgG is a type of antibody, and maybe it's low, but that's something we can monitor. We can see, are the antibody levels sufficient? And so, in addition, when you don't have enough of these cells, sometimes when you give immunizations, maybe you don't get a robust response from the immunization or the vaccination. Okay, so we can see that, or perhaps you've been infected and you would normally produce antibodies to this new infection, and maybe that response doesn't take place normally. When you don't have normal levels of these antibodies, one of the most common findings we can see in patients is that they tend to get recurrent sinusitis or lung infections like pneumonias. Okay, so those are the most common kinds of infections that can be observed. Now, T cells can also be affected, and T cells, B cells, T cells, they work together and then they have some of their own jobs. T cells can be important for a variety of things. You may recall in the early days of discovering about AIDS, there was this type of pneumonia. That's what led to the understanding that AIDS was a problem. There was HIV infection. And those cells that are infected with the HIV virus, when they get very low, they're really important for fighting a particular kind of infection. And that's with this, this organism here. We'll just call it PJ. And you can get infection, we call it PJP, the pneumonia with this organism when those levels are very low, or those particular cells, those CD4 cells, okay? And so the good news is we have medicines that can help markedly reduce the risk of that infection occurring. And so if you know that the CD4 cell count is low, below a certain level, that would be a trigger to start one of these medications to help reduce the risk. And this is a germ, it's just in our environment. You can't get away from it, okay? So now there is a medicine, this is the long name, this is the brand, one of the brand names, Bactrim, it's easier to say, and we often just call it Bactrim. This can suppress the bone marrow, so it may not be a drug that you want to use if the counts are already low. But there are other options that could be used instead. Now, as I mentioned, some patients, they can be born with a very severe immunodeficiency. In fact, the first thought may be that there's a specific defect in the immune system and not a telomere defect. I mean, the first thought is the immunologist, not the hematologist, it's the immunologist who sees a very, very sick infant. These infants, this severe combined immunodeficiency or SCID syndrome is very life-threatening. The children where we've seen this, or at least has been reported in the literature, again, are often patients that have a diagnosis of HH, or they come to that diagnosis. But accompanying this severe immunodeficiency is this severe enteropathy, this disease of the gastrointestinal tract. It's often non-infectious, can't identify an infectious organism, and it's not clear if it's just the GI tract is just not healthy, like the cells aren't healthy and normal, or it could be a combination of the immune system being very abnormal, or a combination of both. But this can be a very, very severe problem. It can be seen in patients with ARTEL1 mutations, but I think some of the other patients that have been reported may have others. They haven't been really well described to date. But the point here is that this is a problem in early infancy, all right? Now, if you don't have this in early infancy, you're likely to develop this very severe SCID phenotype. Instead, some people will go on to develop something that we refer to as common variable immunodeficiency, or something similar to that in adolescence. And this is where there's a reduction in antibody production. So what can you do? So this is where you might just ask your physician, have you looked at my child's immune system, okay? Particularly if there's this history of recurrent sinusitis, for example, just check, did you ever check my IgG level? And maybe they hadn't, and maybe when they check, they discover it's quite low, because there's something we can do about that. So you can ask for antibody levels. IgG is the most commonly low, but there are different flavors of antibodies, and these can be low as well. You can ask to look at the different types of lymphocytes. There's something called a lymphocyte panel, and you can look at the numbers and percentages of T cells and B cells and NK cells, and you can even get into much finer detail of each of these cell types. You can ask to, I've got lymphocytes, but do they proliferate normally when they're challenged with antigens? Do they do what they're supposed to do? And you can also ask, well, okay, my child has got some mildly low IgG levels. Maybe there's a problem with the B cells. And they get the pneumococcal vaccine or something. And then you could say, okay, did they develop antibodies to their vaccination? And sometimes we see that those antibodies aren't kind of popping up, right? So that tells us there's a problem in the response to vaccinations. And again, there are things that we can do about that. And this is another special test that we can do. Normally, all of us, unless we have a blood type AB, we're going to develop antigens over time, or antibodies to the A and B, depending on what our blood type is. And so we can ask, has an individual with a telomere disorder, did they naturally produce these antibodies or not? And that can help us understand how well their immune system is working. Okay? So these are tests that can be done. And again, I think to me, these top two here, usually I would do these two, and if these all look good, I probably wouldn't do these others. But so I just kind of monitor, and I might check, once, and then check a few years later. I don't think they need to be done, every 2 months or 6 months or anything like that. And also, if the patient's clinical situation changes and they're starting to have more problems, that could be a trigger. You don't need to stick to a schedule. If there's an indication to do it sooner, you do it sooner. So we can, as I mentioned, treat some of these things. So if the antibody levels are low, what we can do is we can actually give antibody back to this. This is a pooled antibody, so a variety of antibodies. We don't know exactly what's in there, but it's been pooled from donors, human donors. So this can be administered either through an IV or actually into the subcutaneous tissues. Now, if there's recurrent infection, we would still do this because a lot of these recurrent infections are due to germs that, again, the general population encounters. And so many of those specific antibodies are in that general antibody preparation. We talked about prophylaxis for PJP. And of course, flu vaccine. Is everybody thinking about the flu vaccine? I hope so. We're getting into flu season, okay? So, always, get your flu vaccine, not only for the person who's affected by the telomere disorder in your family, but every member of the family, okay? And this year, there's no flu mist, so we don't have to be advising people, don't do the flu mist, because there is no flu mist. So everybody gets a shot, okay? And then for those patients that have an immunodeficiency and they go on to transplant, often that immunodeficiency will be corrected by transplant. And there's, of course, the whole battery of immunizations need to be reinstituted post-transplant, et cetera, which you've heard about. Okay, so we're going to talk a bit about the eye, and I know a number of people have been interested in learning about eye disease and the telomere disorders. And what we know that these are not uncommon. About 40% of patients with Dyskeratosis congenita, and if we use that basket term, have been defined to have or found to have some degree of complications affecting the eye. If you look at the eye, there's, what we see here on the outside, we've got the lids, we've got eyelashes, we've got this inner canthus right here, which is where we've got tear drainage. And then we've got the lining of the eye, the conjunctiva. And everybody's heard of conjunctivitis before, inflammation, the eye, pink eye. And there's the cornea right over the middle of the eye here. And then we've got the back part of the eye where the retina is, and that's where we get our vision. Okay, very important as well. They're crucial. So we can have, or in the telomere disorders, there can be problems in that those supporting tissues, the anterior part of the eye, as well as the posterior part of the eye. So with respect to the supporting or surrounding tissues, a major problem has to do with the tear ducts. Okay, the duct may be very, very much narrowed. The entry into that duct can be closed. And as we talked about, I think, yesterday morning, our tears will flow through that duct into a sac and then drain into the nasal cavity. So if that's closed, there's nowhere for those tears to drain, which our eyes normally produce. And what happens? There's this constant tearing. Now that constant tearing can lead to some inflammation of the lining of the eye, conjunctivitis. It can lead to inflammation of the eyelids. The fancy term for that is blepharitis. And it can lead to ulcerations of the cornea, which can, affect a vision that would not feel good or be good for your vision. This is just a picture of these ducts, and they drain into the sac, which drains into the nose. Here's another picture of it here. And so what can we do about this? So there are surgical treatments that can be done, and I think maybe some of you have had this done, or you've had family members who've had this done. But there is ways to open the channel, put a little stent in, a little glass rod. There's ways to create additional drainage from the sac into the nasal cavity. I think really the key thing is that you've got to see the ophthalmologist if there's a problem so they can make an intervention, or at least determine if an intervention would be appropriate and helpful. If you don't see the doctor, you're not going to know that. It's nothing you can do at home, right? Now, there can be also a problem with the eyelids and the eyelashes. So often the eyelashes don't grow the way they're supposed to grow. They kind of are growing in the wrong direction. And sometimes the eyelid will turn in or out. It won't be placed along the eye in a normal way. And these problems can also lead to inflammation of the conjunctiva, so conjunctivitis, or inflammation of the eyelid, blepharitis. They can irritate the cornea and cause scarring. And they can also eventually lead to some vision impairment. So again, you want to intervene. If these problems are there, you want to see, can an intervention be made to help prevent a complication that may not be reversible if you wait too long. So early recognition is really key. And so visit your ophthalmologist. And I think it's okay to go see a doctor and they say everything looks fine. And you say, great. If there's a problem, then they can let you know if there's something can be done. But if you don't see them when you've got a problem, then nothing will get done. And so there's surgeries that can be done to repair the way the lid lays on the eye. There can be removal of these wayward eyelashes if necessary. Now, in the back of the eye is where the retina is, and this is where the light and all of our vision, it channels through the retina. This is a critical structure. And so this lays in the back of the eye, and this is what it looks like when a doctor looks through the pupil to the back of the eye. And really the problem that's been best described is this exudative retinopathy, where there's been fluid leakage out of the vessels in the back of the eye into the surrounding tissue. And this has been described specifically, well, it's the defining feature of Evans syndrome. And again, it seems to be present in those patients that have TNF2 mutations, and I don't quite understand the relationship, and I hope someday we will. And it's also a feature of Coates plus. And as I mentioned yesterday morning, Coates retinopathy is a term used to describe this exudative retinopathy that's happening in both sides of the eye. And Coates plus is that, plus a bunch of other things that we talked about yesterday. And it's associated with mutations in these genes. This is very new, but best described with CTC1 mutations. So, and as you can see here, these pictures look quite different from each other. This is not the only problem that can occur in the retina. So other problems, you can get basically an atherosclerosis of the retinal vessels. You can get areas of the retina that don't have perfusion. The blood supply isn't getting to those areas. You can have areas where the blood supply is now abnormal. You've got abnormal vessel growth. That's not too, if you have too little or you have too much, both of those things could be bad with respect to the blood vessels in the retina. And then when you have this exudative retinopathy, that can lead to hemorrhage in the back of the eye and detachment of the retina. And again, this would, can put your vision at great, great risk. So early detection is key. So if there's ever this symptom where all of a sudden, vision has changed, or you sense there might be a change in the vision of your child, you really want a doctor to see that child right away. Don't wait. And if it's something that's acute and you call and they say, well, you could see you in a month, and you're like, no, that's not going to work. I mean, take them into the ER, okay? If there's an acute change, you really want that to be looked at immediately. I think this is one area, and what you're going to see, the flavor of this talk as compared to yesterday, is I'm going to talk about several things that we're becoming more aware of as problems that we can see in DC and the telomere disorders. But we really don't know enough, and we certainly don't have a good sense yet of what are effective and the best treatments for these problems. And I think this is one area. It seems that most of the patients that get this exudative retinopathy, at least those have been reported, are young people, you know, in the first few years of life. It could be that this is just a severe manifestation in these patients who already have other severe manifestations of their telomere disorder. So in other words, sometimes the telomere disorder may not manifest until you're 40, right? So your telomeres are just below the first percentile. We think that maybe is why it takes a while before it manifests in you. And then we have other patients where their telomeres are exquisitely short, you know, and that's detected in the first year of life when they've developed problems. So it could be that this exudative retinopathy is occurring in these patients because they have just really, really severe disease. On the other hand, it could be that if it's going to happen, it happens during that initial phase of development, maybe even in utero, or during the first many months of life. And if it doesn't happen then, it may not happen at all. We don't know the answers to these questions, and I think it's important for us to understand it better in order to figure out how we could treat it better. So we need to really understand the natural history of this, first and foremost. Now, the other area where I feel that we have a lot yet to learn, and it's an important problem, has to do with the gastrointestinal tract. We talked already about leukoplakia and oral problems, but now we're going to kind of move from the oropharynx into the esophagus and talk more about other problems within the gastrointestinal system. So GI manifestations are not uncommon. So it's reported between 10 to 15% of children and adults with telomere disorders will have some complaint related to the GI tract. And what we know about the GI tract, very much like the bone marrow, is that there's a lot of cellular turnover, right? So it's constantly turning over. And you can imagine that could be associated with progressive telomere shortening because there's so many cell divisions that need to happen. So it's not surprising that the GI tract itself would be affected in the telomere disorders. Now, one of the problems that can be seen is this esophageal stenosis, and this is the narrowing of the esophagus, and this is illustrated here. And if you can imagine, here's the mouth, here's the stomach, as food is passing down here and you hit this block, that would lead to very unpleasant sensation. It can lead to a sense of choking, it just, you know, gagging. I mean, just like, you know, the food's not passing, very, very uncomfortable. So it's been reported that this is more often seen in males. I'm not sure if that's accurate or not. It's probably underdiagnosed. People may be tolerating symptoms, adjusting to the problem, and I'll talk about that in a minute, such that we don't really fully appreciate how big of a problem it is. So the symptoms that may be reported, and sometimes we physicians have to be sure that we ask these questions, right? So, and then we probe the patient and say, hey, so do you have any problem? Oh yeah, I've had that problem before. I have that every morning. And so I stopped eating, you know, cereal because I had problems with, you know, that particular thing and I eat something else. So a symptom could be difficulty swallowing or feeling that the food is not passing into the stomach. Sometimes it becomes so severe that people start losing weight. You know, they start curbing how much they eat because they have trouble eating. In babies, this might present as a failure to thrive, where babies just are not taking in much because they're having so much trouble and they're regurgitating or spitting up their formula. It can hurt with swallowing, or there can be the sensation of heartburn. Now, the adaptive behaviors I was describing is sometimes people will very unconsciously recognize to avoid certain kinds of food, avoid certain kinds of pills, for example. I know someone who, for other reasons, likely has esophageal stenosis, and they just will not take any pill that's large. I mean, they have to split the pills because they know they're going to run into problems. Sometimes people will just chew their food a lot, and so, you know, they just take their time and they just chew, and they're able to pass that food more easily. These are behaviors that they may have just developed without even being aware of why these happened. So this is diagnosed using a video swallow study. Now, some people will just do a barium swallow, which is a static picture. That's not going to catch everything you need to do. So this is a video study where you're swallowing barium, and they can see how it passes through. They often have a speech therapist there because they know a lot about how food, liquids pass from the mouth through the throat into the esophagus. So this is one way to establish, the best way to establish the diagnosis, and if it looks like there's a problem, this would lead to an endoscopy, so they can actually look to see what the blockage is. Now, it can be treated. Sometimes it requires multiple treatments to open up the stenosis. And so this dilatation of the esophagus, they go down and they try to stretch open this opening, and they may have to do it many, many times to get it to the point where it's not causing problems. It's important when you have these kinds of problems here, you can get acid reflux, okay? And so it's often important to be on some sort of acid blocking medicine. Now, another problem that we can see, it's got this term, it's called enteropathy. That is the most generic term ever, all right? It just says that there's a disease of the intestine, and we're often referring here to the small intestine. Along with this very generic name is a lot of generic sort of non-specific symptoms that can be experienced. So some people will report this sort of chronic nausea, this intermittent non-localizing abdominal pain. There could be this sensation you eat and you just eat a bit and you just feel full without, being able to eat a full meal. We refer to this as early satiety. Sometimes there could be a sense that they just can't eat certain kinds of foods. They have a food intolerance or an actual allergy, may be reported. There could be issues with the stools or chronic diarrhea. Again, failure to thrive in infants. And failure to gain weight or weight loss in older children or adults. Now, in order to evaluate for this, an upper GI tract endoscopy could be done in a colonoscopy, so to look above and look below. The findings can be quite subtle and nonspecific, so often part of this study is just to make sure that there aren't other factors present, right? So excluding many things, and then you're kind of left with, we think it's just this general enteropathy. And, post-transplant, this could mimic graft versus host disease. So that's important to recognize. Sorry about that. Now the treatment, again, because we don't understand enough about why this happens, we can't prescribe meaningful treatment, like treatments that are based on science, right? Because we don't understand it well enough. Sometimes it's just, adjusting the diet to those things that are best tolerated, avoiding certain things. Some people report it's all anecdotal that going on a gluten-free diet helps, and if that helps, great, all the more power to you. And I think what we need to do is we really need to understand this better through natural history studies and actually having, at some point, gathering individuals together that have specific problems and testing specific interventions and recording how well they work or don't work, and then we can advance the field forward. Now, a more severe problem is this enterocolitis, and I described this briefly in those infants that are born with very severe immunodeficiency. And these are the kids that are found to have HHS. Now, these symptoms are quite severe with severe abdominal pain, bloody diarrhea, failure to thrive. And it can be so severe that the bowel can actually perforate. And this can lead to bacterial sepsis. Well, you can have bacterial sepsis without the perforation as well, but this can be a life-threatening event. Or this could be a life-threatening complication of a telomere disorder. And again, it could be due to the lining, immune defects, or combination of both, and probably is a combination of both. The diagnosis itself can just be made based on the clinical features. No special tests need to be done, but frequently colonoscopies are done and can, again, look for specific infectious processes that may be at play, or at least rule out specific treatable infectious processes. So, we know that's not what's going on, and there's not indiscriminate use of antibiotics. So supportive care is really the mainstay of treatment, bowel rest, and antibiotic support where indicated along with nutritional support, of course. And again, maybe this can improve post-transplant if the immune system is contributing, but there may be patients who don't have full recovery of the gastrointestinal tract, or that may be such a severe complication it may preclude them actually going to transplant. Now, another problem that we're becoming more and more aware of is the development of acute GI bleeding without a real cause, or there's a cause, where we don't know what the cause is yet, okay? And this isn't in infants. We're talking about people and the patients I've heard about to date. These are individuals who are many years post-transplant. And they start to develop these problems where they're having bright red blood or evidence of blood loss in the intestinal tract. If you examine the stool, their hemoglobins are dropping. and lo and behold, they're losing blood in the intestinal tract. Or maybe they actually have vomiting that has some blood in it. And so this unexplained GI bleeding can be quite severe and quite problematic. And when studies are done to try to find the source of the bleeding, it's not clear. There's not an overt, bleeding vessel. There's not a big ulcer. But maybe the vessels that line the intestinal tract don't look quite right, and there's just this generalized oozing that's happening. Now, when people develop portal hypertension, so portal hypertension is when there's impaired blood flow through the liver. When that happens, our body develops the vasculature upstream, down, so you're going up to the liver. So before you get up to the liver, there's all these other vessels that become dilated, and maybe there's some new vessel growth, and they line the intestinal tract. These are called varices, and those can bleed. So anybody with portal hypertension can have bleeding varices. What's important here is that we see patients that have had this GI bleeding, and they may have evidence of portal hypertension, but it's not bleeding varices that seem to be the problem. And many of these patients, they have portal hypertension, but it's not due to cirrhosis of the liver, and that's a major cause of portal hypertension. We refer to this as non-cirrhotic portal hypertension. So the prevalence of this problem in patients with DC is unknown, and it really warrants study. And so I encourage any of you who have encountered this problem to make sure you're communicating. Well, I can't imagine your doctors don't know, but we as a group of people who care about patients with the telomere disorders have begun to think about this and how we might begin to tackle this problem. And part of it's just understanding who's been affected and learning about their particular case. And so we can gather the features that seem to be quite common in the population and those that may be unique to individuals. Now, among the various people that have been affected, a variety of treatments have been used, and typically it's many different treatments have been used because none of them seem to be working very well. So again, we have a lot to learn so we can figure out what the best treatment of this is. Liver disease is another significant problem in the telomere disorders. It can be anything from mild to severe and life-threatening. Signs of liver disease are you could just have increased levels of the liver enzymes in the bloodstream. So if you don't look, you might not see them, right? I mean, you have to look to see them. So periodic checking of the liver panel is an important thing to do so we can detect these problems. You can see decreased levels of the proteins that help clot the blood. The liver produces many of these clotting factors, and when the liver's not working very well, these clotting factors are reduced in the bloodstream, and this can impact the ability to clot. So sometimes we'll just check, does the blood clot properly? And if it does, it gives us a clue that the liver is making enough of these factors, so that's good to know. Looking at the liver by ultrasound is very helpful. When I have a patient who has a new diagnosis of a telomere disorder, I always get a baseline ultrasound, even if the liver panel is fine. I just want to know what it looks like at that point in time. I want to have a baseline exam. I want to know it looks normal then, because that way in the future, if there's a change, I know, well, that is indeed a change. If something looks abnormal, I know it has changed. When there are severe problems with the liver, you can start to see it on ultrasound, and it just doesn't look normal. And then more severely, we can see portal hypertension, and we just talked about that briefly. So to screen for these, again, check liver function tests, look at the ability of the blood to clot. This is another protein, albumin. Albumin is produced by the liver, and when the liver's not working, the albumin levels will go low, and this can cause to some problems like edema into our skin. So this is very important to look for, checking the liver by ultrasound, and doing these more frequently if a patient's on androgens, because androgens can affect these. And if it's abnormal, consider a liver biopsy to get a better sense of what's going on. Is it cirrhosis? Is it not? Now, there are no specific treatments. Liver transplantation can be a curative if there's cirrhosis, for example. However, the patient's got to be able to tolerate a liver transplant. And so it gets complicated, right? Because often patients have other problems going on in other organs like the lungs or maybe the bone marrow. And so this is where I think monitoring over time is really important, because you want to make yourself aware that there's a problem that's progressing. So treatments can be instituted at a time that's appropriate, and we haven't missed the window to treat, the window of opportunity to treat. Does that make sense? Now, what can we do to maybe minimize some of these problems from occurring? Alcohol consumption, obviously, minimize or avoid alcohol because we know that that's toxic to the liver. There are other drugs that are toxic to the liver as well. And yesterday someone asked, oh, how would my doctor know about drugs that affect the blood? Well, there is a wonderful website actually that you can go to that will tell you whether a drug is associated with liver toxicity, and this is in your handout. And so I think this is useful to look at. You know, immunizations should be up to date for hepatitis A and B. Fatty liver fat can accumulate in the liver, and this can cause problems in the liver. And one of the ways you can minimize fatty liver is by minimizing excess weight. So patients that are well overweight often will have fatty liver, and one way to help reduce that is to reduce that extra weight. Okay, so weight management. And then the other thing that can affect the liver is iron overload. And this is something we really have to pay careful attention to. And you wonder, iron overload. So when we give red blood cell transfusions, we're given a huge bolus of iron. Now females, when they have their periods, we lose iron. We don't lose enough, but we lose iron. Males don't have any route to lose iron. And many females who maybe have low platelets maybe aren't even getting their periods, right? And then we're giving them huge amounts of iron with every single red cell transfusion. This needs to be monitored. There are medicines that can be used to help get that extra iron out of our system. And you want to implement these strategies before there's a great deal of iron that it's caused damage to the liver, damage to the heart, damage to various endocrine organs. So it's really important to monitor for this. Is there evidence of iron overload? If there is, there are medicines that we can use to help this. And so, again, assess and treat iron overload if it's found. Now, the last thing I think that I'm going to talk about are pulmonary AVMs. This is another new area of understanding. There are many names that have been used to describe this, and they're listed here. And there have been some periodic case reports, and more recently a report that will soon be published, but has been accepted for publication on a case series of individuals with a DC or telomere disorder that have these pulmonary arteriovenous malformations. So this is what an AVM looks like. Okay, so normally you have your artery, big vessel that branches out, kind of like a tree, and you get more and more branches and more narrow branches. And eventually you get to the capillary bed, where you go from the arterial side to the venous side of this capillary bed. And this is where oxygen exchange happens. This is how we deliver oxygen to our tissues. It's not happening out here, it's happening in these capillary beds. Now what happens when AVM forms is that you don't have this little fine mesh-like network. You have this very tortuous network of these larger vessels, and the oxygen isn't diffusing now into the tissues. So you can imagine that's a problem because you're not getting oxygen to the tissues that it needs to go to. So what's been found is these have been found to occur in the lungs of some patients with telomere disorders. The signs are that they can have shortness of breath. For some patients it's worse when they lay down, and other patients it's worse when they stand up, so it could be either. There's evidence of poor oxygenation. Maybe when we check their oxygen level with a pulse ox, you know, it's low. Sometimes it's detected when people get a DLCO test along with their pulmonary function test, and it's low, and it's sort of out of proportion to other abnormalities of their pulmonary function tests, or maybe those others are just fine. So it's this unexplained reduction in the DLCO. In patients that don't have DC, they can develop something called clubbing of the fingernails. And of course, many patients with the telomere disorders have abnormal nails. Those may not be as obvious to the person who's used to looking for clubbing, because it may take on a different appearance altogether. Now, the best way to diagnose this is something called a bubble study. And I mean, for a young child, if they hear they're getting a bubble study, that might sound kind of cool, right? But a bubble study is a special kind of EKG where there's an echocardiogram where there's an injection of some saline that's got some bubbles, air bubbles, agitated air bubbles that go in, and it allows one to look how quickly those bubbles pass through the right side of the heart, through the lung, and into the left side of the heart. And so this is how a diagnosis of these AVM can be made. Now, an important part of the differential, that is, doctors, when they see these AVM in the lung, evidence of pulmonary AVM, one of the things that we need to consider is it a primary problem there, Or is it actually a primary problem in the liver that's resulting in some effects on the vasculature in the lungs? And this is called hepatopulmonary syndrome. And so, and sometimes this can be seen. Maybe there's cirrhosis, maybe there's not. And maybe there's portal hypertension, maybe there's not. But that's an important thing to consider as well. Is there a problem with the liver at the same time? So pulmonary AVMs can happen in other patient populations as well. And there are some treatments that can be used. If there's one big old AVM, there are surgical interventions that can be used to kind of stop that blood flow through that region. And for patients who have diffuse AVM, maybe there could be lung transplantation can work. But again, if there's a primary problem in the liver, if you transplant the lungs, you still have the primary problem in the liver that can then affect the transplanted lungs. So it's a really important sort of differential that we need to kind of, we need to understand what's driving the process in the lungs. So this is the letter that's going to come out soon, this research letter from many of us that are working together now from many institutions. And we've reported now 13 patients that have evidence of these pulmonary AVMs. They have had their diagnosis of their DC or telomere disorder ranging from 1 to 27 years of age. And for a few patients, actually, their pulmonary AVM were diagnosed before their DC was recognized as being present. So their age and range for diagnosis of pulmonary AVM was between 3 and 32 years. So these are all fairly, the first few decades of life, right? 6 of the patients had TNF2 mutations, but not all. So there was some ARTEL1, DKC1. There was a patient that didn't have a mutation detected to date. So it doesn't seem to appear to be associated with a particular mutation, but it may be those patients who have more severe disease presenting earlier in life. Many, but not all of these patients had already had a bone marrow transplant. So that tells us bone marrow transplant is not required to develop this problem. 9 of the patients did not have any evidence of liver disease at the time of the diagnosis of pulmonary AVM. It was not detected. It doesn't mean that it's not going to develop, but at the time it was not detected. And interestingly, 2 of the patients were asymptomatic. This was just, the diagnosis was made after they had pulmonary function tests with DLCO. The DLCO was low, and that led to additional studies in which these were identified. The patient wasn't even experiencing any symptoms at the time. So with these patients, what we know now is that there's, at least among treatments that have been tried, there hasn't been any effective therapy identified to date. Again, these are individuals at individual institutions trying to think about what might be an effective treatment. This is, again, an area where we really have to understand better the natural history and come up with treatment studies to see if we can help the course of this complication of DC. Okay, this is pretty much my last slide. Okay, so what I want to just point out, I have talked about a litany of problems, and I hope I have made it very clear not everyone gets everything, okay? That's very important. And so all the advice that I've given, it's got to be tailored to you or your child's specific case. I think it is really important to think about drugs that are being administered to treat various problems, just to make sure, are they drugs that can affect the liver? Are they drugs that can affect the lung? Just very important consideration, but recognize that sometimes we do need to use things because that's going to help a big problem rather than a potential problem. Sometimes you need to educate your doctors. You might go to a doctor who's not heard about DC before, and so recognize that all of us are always willing to help other physicians in the country who may not have had experience with patients with telomere disorders before. And you can refer them to us, you can refer them to the DCO website, and now we've got that awesome guide, which is online. There's just no excuse, and sometimes you can even, in advance of a visit to a new doctor, just send their office a note saying, I do have this rare disorder, and I just wanted the doctor to know this is a really great resource, because no doctor wants to be in the dark. They want to know as much as they can, and so if they have been pointed to a really good resource, they'll be appreciative of that. And at the end, you know yourself better than anyone, and you know your child better than anyone. So really trust your gut and voice your concern, and you will always be the strongest advocate for you and your child that there will ever be. And so with that, I also just want to say that, I said this last time, I truly believe this is a case that, what we know today is not the same thing we're going to know 5 years from now and 10 years from now. So I'm always very hopeful, and I hope you are too. But as we work together, I think this is how we're going to get to a better day for everybody. So with that, I want to say thank you, and feel free to ask any questions.